Okay, guys, so now we're going to be talking about the medical management and rehab intervention for patients post spinal cord injury. So, this is pretty long PowerPoint because it was combined with a 30-page lab handout. So, that's why this is so lengthy. A lot of the slides are going to consist of some of the pictures of interventions and some of the equipment that is used with patients with um, spinal cord injury. So during those early stages, the emphasis is going to be on either surgical decompression if surgery is required or stabilization using cervical orthoses. Immobilization of those fractures that are unstable is going to be achieved via skeletal traction through either tongs or a halo. And in the next couple slides, we're going to be talking about both. Turning beds are also used at times. Cervical orthoses, such as the halo orthosis, Minerva, cervical orthosis. Pressure relieving mattresses are also used, sometimes made of gel, sand, water, air, foam, or rotating mattresses. And the patient can also use a thoracolumbar sacral orthosis, which is that plastic body jacket that you have seen in prior presentations regarding orthotics. So during this acute stage, to stabilize the cervical injury, immobilization is very important. And as I said before, it's through tongs or the use of a halo, which you saw in the last slide and we're going to be seeing again soon. So the tongs are inserted laterally on the outer parietal portion of the skull, and then it is attached to a rope traction pulley system with the patient in supine position, as you see here. And this is how they achieve the traction. Surgical intervention may also consist of stabilization of the spine, generally with the use of rods, plates, and screws. Now this is the halo device, which consists of a halo ring with 4 screws that attach to the outer skull, which is attached to a body vest that you see here. These allow earlier progression to that upright position and allow rehabilitation to start earlier because the fracture is stabilized or the spine is stabilized, therefore the patient may initiate some type of rehabilitation program. The patient will remain in the halo for about 12 weeks, followed by a cervical orthosis or a brace for about 4 to 6 weeks. Again, every spinal cord injury is going to be different depending upon the severity of the injury. Some clinical information regarding the halo orthosis. The halo provides stabilization at all cervical levels. However, no brace will ever guarantee the maintenance of the alignment. Just a couple of a good information to remember when patients are using this halo orthosis and you are treating these patients. You obviously never want to grab onto the halo frame for any bed mobility or transfers or any other activity. Beware of the halo projections to prevent injury to yourself during any types of bed mobility or transfers. The prone position is really not used early on, but it may be approved by the physician later on. A patient with a halo orthosis will not perform bridging. That is just going to not only increase the pressure on the spine, but it may be uncomfortable for that patient because they have these projections coming out of their head. A patient with halo will avoid scapular elevation, so shoulder shrugs, any overhead activities above 90 degrees of flexion, abduction, or scaption, because those activities could increase the load on the cervical spine. This is to be done only if directed by the physician. You want to check with the supervising PT, the plan of care, the facility policy and procedure, and physician clearance regarding the amount of weight to be used for any type of shoulder activities. There may be no shoulder activities early on in the recovery, but maybe later on they may be added to the plan of care. Always refer to the plan of care, the supervising physical therapist, and the facility policies and procedures, and the physician's clearance for specific activities with these patients. Here in this slide, you see the Minerva orthoses for cervical injuries below C2. Again, they are a little less invasive than the halo orthosis, but it's just another option dependent upon where the injury is located. These are meant for cervical injuries below the C2 level. This slide contains a picture of the roto rest kinetic treatment bed, and this patient is requiring continuous side to side rotation while keeping the spine immobilized, but it helps with pressure relief and it also helps with pulmonary drainage and kidney drainage for that patient that requires that constant mobilization and is unable to due to spinal cord injury. These are just some mattresses that are used, hospital beds that can be air fluidicized to help prevent pressure ulcers. They can be made of gel, they can be made of foam, as well as water. So for those thoracic and lumbar fractures or injuries, the TLSO is usually the choice of orthoses, and this is a thoracic lumbosacral orthosis. It is this one on this area here in the corner, and this is a body shell, a clamshell, or a turtle shell that is the design. And the design is going to be obviously to improve that stabilization as much as possible. So it is going to be a rigid frame. Um, you want to take into consideration, you want to maintain a log roll position for any type of changes while in bed. The TLSO allows for that earlier rehabilitation to start due to that immobilization and stabilization of that fracture. Surgical intervention, dependent upon if the patient required surgical stabilization, then the patient will be placed typically in a brace for around three months. I've seen patients in the clinic for about 4 months of wearing this thoracolumbar sacral orthosis. So during this acute stage, there are several things that we're going to be wanting to emphasize in order for our patient to safely progress to the next rehabilitation phase. During the acute phase, the interventions are going to consist in respiratory management, range of motion, and positioning. Please look at page 872, table 20.3, selective strengthening, and orientation to the vertical position. All right, so during this phase, the acute phase, specifically dealing with respiration, our goals are going to be to improve ventilation, to increase the effectiveness of the patient's cough, and to prevent chest tightness. And based off of those three goals, the interventions are going to may include breathing exercises, the facilitation of expiration, as well as using mirrors for visual feedback. These are some of the interventions. But respiratory care is going to vary according to the level of the injury and the patient's respiratory status. So, depending on the patient, the following may be applicable. The patient may benefit from glossopharyngeal breathing, which a patient is instructed to take small amounts of air using a gulping pattern. And this is through the use of using the lips, the pharyngeal muscles, and the tongue to inhale air. So the patient is told to take in small amounts of air and repeat that about 6 to 10 times. It allows for those patients to breathe independently who are ventilator dependent. Again, these are all options. It really depends on the patient, the level of the injury, the severity of the injury, which technique we can use with which patient. An assisted cough is also another option for patients. In this, you can see a picture on page 873, figure 20.7, where the clinician is placing his hand on the epigastric area of the patient, and they are assisting that patient to cough. An abdominal binder or corset, which you see in the picture on the slide, may compensate for those non-functioning abdominal muscles in order to help with respiration as well during this stage. And also stretching of the pectoralis muscles and other chest wall muscles to prevent any type of chest tightness is very important. Okay, guys, so during the acute stage, we also want to focus on range of motion, and there are certain things that we want to avoid. So the first one being avoid straight leg raises more than 60 degrees and hip flexion beyond 90 degrees if the injury is in the lumbar spine. And the reason for this is because we want to prevent any strain or any increased pressure on the thoracolumbar spine. After that acute stage, the straight leg raise, you want to limit it to about 100 degrees, and then eventually you'll start progressing it towards that 120 degrees. Cervical range of motion for patients with tetraplegia has to be cleared by the medical doctor in order for us to initiate that. And you also want to remember that you do not want to stretch tenodesis grip for patients with tetraplegia because we use that tenodesis grip to the advantage of the patient's functional status. So we're going to talk about that a little bit more in some upcoming slides. All right, so now we're going to talk about passive range of motion during the initial flaccid state. You want to make sure that any extremes in range of motion are avoided because you do not know the patient's normal range of motion prior to this. As far as scapular mobility, we want to do passive scapular motions, but we don't want to pull on the arm to accomplish this. The motion should be controlled. Shoulders, we want to maintain all range of motion. This is including horizontal abduction because we want to prevent any tightness in the pecs. We are going to discuss some special considerations for patients with tetraplegia. As far as the elbows go, you want to make sure that for those patients with lesions above C7 that we stretch the elbow flexors because they are more prone to getting an elbow flexion contracture because the triceps are not innervated yet. The triceps come in at C7. Therefore, the strongest muscle is going to be the elbow flexors, which the patient is going to be more prone to getting into flexion of the elbow, therefore may develop contractures in the elbow, in the biceps, or all the elbow flexors. So it's important for us to come in and stretch those elbow flexors to prevent development of that flexion contracture. For the wrist and the hand, for C5, C6, and C7, they're going to require a tenodesis hand grip. So this tenodesis is very important for us as a therapist not to stretch it because we take advantage of this grip in order to have the patient increase their functionality with their hand. So what this tenodesis grip is when the wrist is in extension, the fingers are going to flex. And when the wrist is in flexion, the fingers are going to extend. So we take advantage of what is happening with the fingers in order to work on tasks such as gripping smaller objects in the hand, so to increase the patient's functionality. So it's very important for you as therapists not to stretch this because in patients for C5, C6, and C7, we take advantage of this grip in order to increase their functionality. In the digits, we want to keep the wrist in neutral. The MP should be flexed to 90 degrees. Then we should provide range of motion to the IPs, and we want to range the MPs with the IPs in flexion. This is all obviously to maintain that tenodesis grip. Therapists should not be stretching the patient's hand out, extending the wrist and extending the digits, because then we lose the advantage that we have of being able to use that grip for functional purposes. We also want to maintain the web space. This is a little space between your fingers. We want to make sure that this is not lost either. Other patients can have regular range of motion to the wrist and hands. It all depends on the level of the injury. So this is a slide dedicated specifically to that tenodesis grip. And here in the picture at the top, you see this patient has a universal cuff attached to their hand, and we use the tenodesis grip, the tightness of the long finger flexors, to provide an improved tenodesis grasp. So this universal cuff, we can attach a spoon, a fork, as you see there in the picture. We can attach a toothbrush to make that patient with the extension be able to flex their fingers around the toothbrush, or with extension to put with flexion to open up their fingers to put that toothbrush down. So this is a way for us to take advantage of that grip. Patients with active wrist extension can learn to use the tenodesis grasp to use their hand and fingers to perform ADL, to manipulate and hold objects without active finger control. So when the wrist is actively extended, the tendons of the fingers are shortened, causing the fingers to flex and grasp. And when the wrist is flexed, the tension in the tendons is then released and the hand opens, providing a release. So this pretty much explains to you why it happens. It is not a reflex. It is just what is happening with the fingers due to the tension in the tendons. And once we release that tension, when we flex the wrist, then the hand kind of opens up and the fingers extend. Extremely important for you to know the positions of the wrist and what it does to the digits in both extension and in flexion. Continuing on with the lower extremities, for the hips, if possible, you want to range in a supine position or a side lying position to prevent a hip flexion contracture. We are going to talk about some special considerations for patients with paraplegia. At the knee, flexion and extension, passive range of motion is appropriate. If the hip has any precautions, then you want to put the patient in a frog position to flex the knee. So a frog position is basically slightly bringing the hip into abduction so that you can bend the knee without altering the hip motion as well, or breaking any type of precautions that the patient may have at the hip. At the ankles, you want to make sure that you provide a minimum of neutral dorsiflexion for function, and this is obviously for wheelchair positioning. For transfers, the ankles have to be at least to a neutral position. And then for the toes, you want to watch out for toe flexion contractures, so you cannot forget the toes when we are doing our passive range of motion to patients with spinal cord injury. So some special considerations that I had mentioned from prior slide for patients with tetraplegia, also known as quadriplegia. This is paralysis of all four extremities and the trunk. The motion of the head and the neck is contraindicated until clearance is given by the doctor, by the medical doctor. Hamstrings need to be to 100 to 120 degrees for any functional activities. Until the cervical spine is stable, there should be no shoulder flexion or abduction beyond 90 degrees, because we don't want to put any type of strain on the cervical spine by bringing those arms, those upper extremities, into more than 90 degrees. Some doctors may not allow any shoulder flexion or abduction, but obviously you want to make sure that you find out before you start your treatments with these patients. And with patients with tetraplegia, there should be no twisting motion, so we should be doing log rolling techniques or segmental rolling, making sure that there's no twisting done. So typically just the log rolling technique for this patient. And the special considerations for patients with paraplegia: now the patient has paralysis of two extremities, as well as some of the trunk, depending on the level of the injury. Motion of the trunk and some motions of the hip are contraindicated, but you want to use the guidelines to avoid strain on the thoracic and lumbar spine. With hip flexion, you want to make sure that the hip is flexed with the knee flexed to 90 degrees only in the acute period, and straight leg raise should be only from 30 to 60, and then slowly progressing as the patient is improving in their rehabilitation. The reason being is we don't want to put any more stress on that thoracolumbar spine. To move in the bed, we want to make sure we use the log rolling technique to avoid any disruption in the injured area. And dependent upon the level of the injury, the patient may also require 100 to 120 degrees of hamstring flexibility. However, the acute stage is not the time to work on this. So you just want to make sure that you stay within those guidelines that we talked about prior, which are straight leg raise from 30 to 60 and hip flexion with the knee flexed to 90 degrees only. And then we progress in the later stages of rehabilitation. Okay, guys, so now we're going to talk a little bit about positioning during the acute stage of injury, post injury, and positioning helps to maintain patient range of motion. As you see here in some of the pictures, you see some of the positions that our patients are put into. This is to maintain range of motion. Some of the orthoses that we talked about already during the first week of the course are the multi-POTUS boot or any foam boots. This is to promote range of motion, maintain range of motion, to prevent any type of pressure ulcers, and to encourage proper positioning. So some caution that we have to have with any type of device that we use for positioning is sometimes it may not be achieving the purpose that we want it to due to the patient sliding out of the device with any type of motion that they're doing. Could be lower extremity, could be upper extremity, obviously dependent upon the patient's injury and what they have available. But we just have to make sure that the devices are placed correctly to avoid any type of symptoms that we don't want with the device or any sliding out of these devices. So just a couple of areas where it is important for us to look for any areas with erythema, with rashes, bruises, or any indentations. This patient is going to be bedbound for a while. Also, wheelchair bound maybe for the rest of their lives. So it's very important for us to educate the patient, the family members, caregivers on skin inspection. And this slide just gives you a couple of areas that are very important to focus on when the patient is in the bed, in a supine, in any position really, and also when they are seated in the wheelchair. So what we want to look for, as I mentioned prior, any areas that are bruised, scraped, any indentations. We want to check for blisters, dryness in the skin or any pimples, any thickening or change in the texture, especially over the bony areas. We also want to focus on checking the toenails for any erythema or any pus formation around the end of the nail. Whenever you notice any type of problem, you want to try to figure out where it's coming from, and you want to make any necessary changes that can be easily made by us to prevent any further problems. We also want to make sure that we inform the physical therapist as well as the nurse to make sure that the patient's nurse and the doctor are aware of any problems that arise with this patient's skin integrity. You want to know that prevention is key. So the earlier we catch any type of problem of this type, the better prognosis the patient is going to have from developing an ulcer in the future. Now we're going to be talking about selective strengthening, and selective strengthening is basically we want to cautiously pick and choose the muscles that we want to strengthen. We want to make sure that we follow these three rules in avoiding stress on fractured or unstable areas. We want to avoid scapular and shoulder strengthening in patients with tetraplegia, as you remember from the slide on special considerations for patients with tetraplegia. We want to avoid any pelvis and trunk strengthening in patients with paraplegia. We want to integrate bilateral upper extremity exercises while emphasizing symmetry and prevention of spinal rotation. We want to use manual resistance in straight planes, PNF patterns, using cuff weights or dumbbells. Okay, guys, so now we're going to talk about active range of motion, active assistive range of motion to mild selective strengthening. So during this acute phase, we just want to focus on the muscles that the physician has cleared us to start strengthening. And we want to strengthen muscles with caution. And there are some considerations and some contraindications that we have to take into account with patients with tetraplegia. So the muscles of the scapula and the shoulder, resistance is absolutely contraindicated. This is because we don't want to put any type of increased stress on the area of injury. And if we start strengthening these muscles and adding weight, we're putting more stress in that area that has been fractured. So you want to focus on doing symmetrical and mild strengthening, active range of motion as possible, if possible, with the distal joints, but not adding any resistance. For patients with paraplegia, the muscles of the hip and the trunks, resistance is contraindicated as well. For the same reason, we do not want to put any added stress to the area of injury. You want to work on all upper extremity musculature with emphasis on the triceps and the latissimus because these are very much required when the patient is working on transfer training as well as required for ambulation. Okay guys, so the next thing we're going to talk about during the acute phase is orienting the patient to vertical position, and this is the gradual acclimation to that upright position to compensate for orthostatic hypotension. This patient has been laying down for days, weeks at times, and gradually means over the course of a session and not over the course of several days. We want to make sure when we are starting to bring this patient into an upright position that we always monitor vital signs to see how they are reacting to the change in position. You can do this by several different routes. It could be simply elevating the head of the bed, maybe using the tilt table, putting that patient in a reclining position in their tilt and space wheelchair with elevating leg rests. Or it can just be bringing the patient into an upright sitting position. Before we do any of this, we want to make sure that the physician has ordered for the patient to sit or stand or use the tilt table. For the tilt table, you want to check with nursing. You want to set up a time. You will need help to do the transfer. Usually it's done with a technician or a rehabilitation aide. You want to schedule this within your department because you're going to have to be performing this procedure for maybe half an hour to an hour. And don't expect nursing to help you because they're very busy. They typically do not have time. You want to make sure that the patient has their compression stockings on as well as the abdominal binder if appropriate. So for the tilt table transfer, since you have practiced it in patient care, I'm going to review it briefly. You want to make sure that you arrange any IV poles, any respirator hoses that the patient has. You want to take vitals prior to the transfer to the tilt table so that you have your baseline. You want to explain to the patient what you're going to do prior to doing it. You want to attach the straps from the tilt table to go over the knees, the ASIS, and the chest region below the breast tissue. You want to reassess vitals after the transfer and begin incrementing the angulation in 5 to 10 degree increments. At each 5 to 10 degree increment, you want to monitor the blood pressure. So you would always leave the blood pressure cuff on the patient so you can just reassess every time. You want to recheck vitals at each 5 to 10 degree change. You want to pause for about 1 to 5 minutes at each 5 to 10 degree change and then reassess vitals prior to moving up another 5 to 10 degrees. You should be communicating with your patient throughout. You should be monitoring vitals. You should be observing your patient from top to bottom to make sure that you look at any response throughout the process. You want to watch for postural hypotension. You want to also watch for signs of autonomic dysreflexia. A gradual acclimation to the upright posture is most effective. If you're using the bed, initially you want to elevate the head of the bed and then progress to a reclining wheelchair with elevating leg rest using all the above monitoring procedures and preparation. So you want to treat the patient, whether you're using a tilt table or whether you're using the hospital bed and just bringing it up, you want to treat them the same way. You want to assess vitals at the beginning and assess vitals every time you increase the inclination. Okay, you want to document all these vitals. You want to document the time that was spent at each interval, and you want to document patient response. So very, very important. It's a procedure that takes about an hour, dependent upon how much time the patient is spending and how much time the patient is able to go up within the tilt table. Okay, and then make sure that you are aware that documenting is extremely important as to the next therapist that may see this patient so that they know what the patient was able to tolerate with you during your treatment session. So during this acute rehab phase, wheelchair management is very important. It all depends on the level of injury and the functionality the patient has available based upon the level of injury. So management of wheelchair accessories, it's important to manage the brakes, the footrest, the armrest, the quad pegs as needed depending upon the patient. Wheelchair skills, it's very important to educate our patients on propulsion, navigation, on level surfaces, and obviously if the patient is able to functionally, then we progress to advanced skills such as uneven terrain, doors, wheelies, up and down curbs, transfers from floor to wheelchair, and from wheelchair to the floor. Okay, prescription wheelchairs. Usually wheelchairs is the primary mode of locomotion for this patient. They may be needed even if they're ambulatory because those patients will get fatigued easily, so they may need a wheelchair for long distances. But we're going to be talking about later on in this presentation about the level of injury, what muscles are available during this level of injury, and what can the patient functionally do. So you're going to see at each level the assist is going to decrease as the levels go down the spinal cord. So it is also very important for you to know the types of wheelchairs that the patients may have as well as what you may come across. So we have manual chairs, we have power chairs, rigid, folding chairs, tilt in space, as well as reclining wheelchairs. As you saw several of them throughout your patient care class. Pressure relief is very important for our patients. This is something that we need to teach them from day one. Pressure relief every 10 to 15 seconds for every 10 minutes of sitting is very recommended for our patients when they are able to sit down. Again, remember that the physician is the one that dictates when the patient is able to start sitting up and start standing up. Some techniques that you guys are going to become familiar with for pressure relief in the wheelchairs are wheelchair push-ups, lateral lean, hooking of the elbow or the wrist around the push handle and lean towards the opposite wheel to try to relieve some of the pressure on some areas. Or you hook the elbow or the wrist around the push handle and then lean forward to try to relieve some of the pressure off of the ischial tuberosities. So these techniques we're going to be talking a little bit more about specific to where the injury level is going to be, but it's just to introduce you to some of the techniques that we use for patients post spinal cord injury. And these do typically start in the acute rehab phase for some patients. Alright, since we are done talking about the acute rehab phase, now we're going to move into the active rehab phase or subacute rehab phase. Now we're progressing to the active phase of rehab, meaning that this patient is now functionally able to do a little bit more because they have been stabilized by the medical doctor, as well as the initial stages of acute rehabilitations have commenced. All right, guys, so the active rehab phase, and what does that mean? That means that at this point, the patient is going to be more stable and is going to be able to do more things. So the next several slides are extremely important because they are going to detail the functional expectations that we have for these patients after spinal cord injury. And your O'Sullivan book is going to be extremely important because it details in a page that is covered in about 3 or 4 pages. Page 883 is where it starts, table 20.5. It is used as a guideline of the normal areas of innervation and what those normal areas of innervation are going to provide as far as what movements the patient is going to have, and with those movements, what functional capabilities does my patient have? And furthermore, it's going to give you the equipment and the assistance that is required by those patients. So, once again, this is not an absolute set in stone table that every single patient with a C5 is going to present just like this. It is just to give you a good guideline of normative values and make sure that you are very comfortable with this table, and going forward into your clinical practice as well as your board examination, you have to be very comfortable with this table. So with each level that we're going to be going through, we're going to be talking about key muscles that are innervated at that level. And the more muscles that are innervated, the more functional capacity the patient is going to have. So each muscle that is going to be innervated at each different level as we go down the spine, it's going to add more significant motion to that patient and more ability for that patient to perform functional tasks. So the goals during this active rehab phase are going to be to maximize functional independence, to instruct the caregiver or someone to assist the patient. They may require a personal attendant. Initially, it's going to focus on a lot of bed mobility activities, a lot of transfers, and a lot of wheelchair mobility and skills. Then we're going to progress to the skills required to return back to work, to home, to school, or to the community. So these are all PT in the subacute phase. Since we moved out of that acute phase, we're now into the subacute phase. So treatment from the acute stage will continue as appropriate based upon the level attained during the acute care. Emphasis will be on continuing to be on respiratory range of motion, stretching, positioning, and strengthening. And obviously now we're incorporating ADLs. The emphasis is going to be placed also on regaining postural control, regaining balance, whether it be seated balance, that's where we start with, and depending on the level of the injury, may be progressed later on to standing balance if appropriate, and also motor control as well. Cardiovascular status should also improve with time and with the increased activity level. The more we do, the more your cardiovascular system is going to respond and adjust as we go along in the progressions of the treatments. So respiratory management in subacute focuses on good posture. It is very important in sitting to prevent restriction of the diaphragm, so upright posture. The higher lesions with paralysis of the abdominal muscles and the rib cage may initially have problems when sitting upright. The abdominal wall in this position is going to physiologically fall forward because it is not innervated with these higher lesions. Therefore, the diaphragm is going to flatten. With that diaphragm in the flat position, it's going to impair the muscle. So in order to compensate for those abdominals that are not innervated and are not working properly, we can use an abdominal binder to help this. but make sure that you do not position the abdominal binder over the ribs because it's going to be counterproductive. You want to put it between the patient's waist and the patient's glutes. Over time, the individual is going to adjust and it may no longer be required. But please make sure that you do not put it in over the ribs because what are you doing when you're putting an abdominal binder over the ribs? You're just restricting the normal motion that we have when we breathe, so you don't want to restrict that. You want to continue with respiratory exercises. So breathing exercises that we talked about during the acute stage, if appropriate, you continue with those. Respiratory hygiene must become a lifelong process to clear the airways. Assisted coughing, also called quad assist cough. Lesions of C5 or above are going to need assistance with respiratory management. Lesions of C6 and down can lean forward with their arm pressing into their belly in the wheelchair, and the other arm may be hooked in order to assist themselves into a coughing. Again, coughing is very important because we want to make sure that the patient is able to clear their lungs. It is also important that the patient coughs several times a day. Again, with what I just said, you make sure you want the patient's lungs to stay clear. So moving on to stretching and range of motion during this subacute stage or the active recovery phase, you want to utilize spasticity reducing techniques. So the inhibition techniques that you learned already in this class are very appropriate. You want to stretch tight muscles, especially the hamstrings, because if you recall from prior slides, you need about 100 to 120 degrees to perform functional activities such as long sitting and performing some ADLs. You want to stretch the gastrocs, you want to stretch the soleus as well as the hip adductors. This is going to be patient dependent. So it depends on your patient and how they present and what type of injury they present with in order for you to stretch certain types of muscles. Shoulder range of motion has to be maintained. Just mind, obviously, impingement and subsequent tendonitis is a common problem in these patients, so you just have to be careful. It is important that they are very mobile in order to be functional. They have to be taught ways in order to move in bed so that they can increase their functional capacity and increase their independence as well. In the patients who lack a lot of trunk control, it is okay to allow the lumbar paraspinals to tighten slightly to provide greater stability with sitting. So if you recall from our lecture in Therapeutic Exercises 1 where we talked about how the lumbar paraspinals will provide that stability as that physiological back brace to the spine, it is okay for patients who lack this trunk control due to spinal cord injury to tighten and to contract those slightly to increase the stability, especially when they're sitting down. You want to continue to allow for tenodesis of the long finger flexors for patients with C5, C6, and C7 injuries. Just a review for tenodesis. Tenodesis is going to be with wrist extension. Your fingers are going to flex, and with wrist flexion, your fingers are going to extend. What do we use this for? Do we want to stretch tenodesis? I'll let you answer that. All right, so now we're going into the table of what are our functional expectations or functional capabilities of our patients based upon what level the injury is, what muscles are going to be innervated at this level, and what can the patient do? What can the patient do, and what are the required equipment that this patient may be able to utilize? So we're starting with level C1, C2, and C3. C4 is also included in the same category within your text on the table, but we're going to follow what is on the slide. So level C1, C2, and C3, the muscles that are available are the facial muscles, the sternocleidomastoid, the capital extensors, the trapezius, the levator scapulae, the partial diaphragm is innervated, not the full diaphragm. At level C4, what changes is the scalenes come in, as well as now more of the diaphragm is innervated, plus the muscles from the previous C1 through C3 category. So each time, please know that at each time we go down a level, the previous muscles are also brought over. They're still available. So the functional expectations for these patients, so with the muscles that I discussed in the slide prior, the patient is going to be able to talk, they're going to be able to chew, they're going to be able to sip, they're going to be able to blow, and there's going to be scapular elevation. So, with all of those motions, it kind of gives you the level of functionality this patient is going to present with. So, this patient is going to be dependent in all ADLs. They're going to be dependent in coughing. They're going to be dependent in range of motion and positioning. They're going to be dependent in skin inspection. So, education is extremely important so the patient can tell others what they need and what they need done. Okay, they will need a tilt in space wheelchair. Is the wheelchair that you see in the top. The second picture from the left is a tilt in space wheelchair you learned from patient care. Also, the controls for the wheelchair, they're not going to be able to control it because they don't have any upper extremity motions because the muscles are not innervated at that level of injury. So they're going to be needing either a chin control or a sip and puff, where they sip or they puff, and that's how they're going to control the wheelchair. Um, they're going to be independent in power wheelchairs if they're able to use these two mechanisms, which whether it's a chin control or a sip and puff wheelchair. This patient, if this is the level, if it's a complete injury or incomplete, and this is what they're going to, their injury is not going to improve, then they're going to require a full-time attendant because they are dependent in all of these functional tasks that we talked about. So now we move on to C5 and what muscles are innervated at the C5 level. So if your patient is a C5 spinal cord injury patient, then the biceps, the brachialis, the brachioradialis, the elbow flexors are all innervated. The deltoids are innervated, the infraspinatus, the rhomboids, and the supinator. So with that said, the motions that are available are going to be elbow flexion, supination of the forearm, shoulder external rotation, shoulder abduction and flexion to about approximately 90 degrees. Once again, the table is not all inclusive, so it's not going to be like this for every single patient that is a C5 spinal cord injury. With those muscles that are innervated, now the functional capacities improve for this patient with a C5 spinal cord injury. So now the patient has the ability to do all those motions that I mentioned in the prior slide. So they may be able to use a handheld power control electric wheelchair, but they can also propel a wheelchair with hand rim projections, as you see in the picture at the bottom there. They may still be dependent for skin care. They're going to be dependent for bed mobility. They're going to be dependent for transfers as well. For coughing, they may need assistance, but it definitely is better than the C4, C3, C2, and C1 level. They may be independent with wheelchair pressure relief, using a tilt in space wheelchair, possible forward and lateral relief with biceps in the chair because they have the biceps. The possible long sitting with arm support, so maybe short sitting, but short sitting may be more difficult for this patient. Prone on elbows, if it doesn't compromise the respiratory system, may be appropriate for them. And they most likely will require a full-time attendant for a C5 spinal cord injury patient. Now we move on to the functional expectations for patients with C6. So a spinal cord injury for C6 level, the muscles that come in are now the extensor carpi radialis, the infraspinatus, the latissimus dorsi, the pec major, the pronator teres, the serratus anterior, and the teres minor. So with that said, a lot more muscles kicking in. So your patient is going to be able to perform shoulder flexion, shoulder extension, internal rotation, adduction, scapular abduction, protraction, upward rotation, pronation of the forearm, and wrist extension. Wrist extension will not include the finger flexors as well, so we still take advantage of that tenodesis grasp. So the functional expectations for a patient with a C6 spinal cord injury is they may be more independent in bed mobility by the use of rolling techniques. There will be more independence in transfers with the transfer board on level surfaces. There will be more independence with manual wheelchair with projections or friction hand rims, but they will still need an electric chair. Independent with cough and pressure relief. They will be independent with long and short sitting, balance and functional movements in long sitting. Independent with pronon elbows, once again, if respiratory is not compromised. And they may need a part time attendant to help with their functional tasks and ADLs as needed. So here we have some pressure relief techniques. The gentleman in the red shirt is C5, C6, and he is using the pressure relief techniques of leaning over to the side. So he's just kind of shifting over to one side and relieving some of the pressure on the left side. And then he's leaning forward to relieve some of the pressure from the back. And then he will lean over to the other side to relieve some of the pressure on the right side. So these are good techniques to teach our patient. Obviously, he is strapped with a seatbelt for safety, but these are the techniques that we teach our patients, teach our caregivers in order to prevent any pressure ulcers from occurring. The gentleman to the right with the black jacket is most likely a C7 spinal cord injury, and the reason why is because he's using the rims of the wheelchair to push up. And in order to extend your elbow like that and push up, you have to have your triceps available. Therefore, when we talk about C7 in the next slide, you're going to see that that's one of the muscles that comes in at that level. So functional expectations for patients with C7 as well as what muscles are innervated now are the extensor pollicis longus and brevis, are the extrinsic finger extensors, the flexor carpi radialis, and the triceps as well. So C7, there's going to be now some elbow extension, some wrist flexion, as well as now some finger extension. So the functional expectations of these patients are they're going to be independent with transfers with or without a transfer board. They're going to be independent with self range of motion, with bed mobility. They're going to be independent with short and long sitting, prone on elbows, pressure relief techniques, and coughing. Manual wheelchairs with friction surface hand rims will possibly, but will possibly need an electric chair as well. Independent living is possible at this level of spinal cord injury, and the patient can drive with the use of hand controls. So the car has to be set for them, but they are able to drive at this level of injury with adaptive controls in the car. All right, now talking about the functional expectations for patients with C8 spinal cord injury. The muscles that come in at this level are the extrinsic and intrinsic finger flexors, the flexor carpi ulnaris, as well as the flexor pollicis longus and brevis. So now my patient is able to have finger flexion available. And with that, my patient now has all upper extremity muscles innervated. So my patient will be able to use a wheelchair with standard rims. They will be independent with all ADLs. They will be able to independently live by themselves, maybe with an attendant to help with other things. And wheelchair wheelies on 2 to 4 inch curbs may be done. Once again, if you're teaching your patients wheelies, you want to have these done in a controlled, safe environment. So having a mat available, having a gait belt that you can strap to the back of the wheelchair to give that patient a little bit more security, and so they know that they're safe. As you know, the anti-tippers in the back have to be removed in order for those wheelies to be performed on 2 to 4 inch curbs. So this is a skill that is actually practiced, has to be practiced a lot with these patients to make sure that they are safe. So it would be a good idea to practice yourself so that you can then tell your patient when you're practicing with them the tips and tricks that you used to complete these wheelies. But safety definitely is the number one priority. The patient needs to feel safe. The patient needs to feel supported by you while you're performing this training with them and their family members. So I hope that you can see how from C2, C3, C4, we in C1 we kind of progressed, and as we went further and further down and the injury became lower and lower, the patient has a better prognosis and more functionality. So that's how it's going to work for the rest of the spinal cord. So now guys, the book kind of groups together T1 to T12. Level T1 to T12, the muscles that are innervated are the intercostals, the long muscles of the backs, just the sacrospinalis and the semispinalis, as well as the abdominal muscles. The abdominal muscles, it's very important to know that approximately around T7 and below is when the abdominals start being innervated. Right? So that's going to be very important to remember. This patient's functionally, they will be able to have better improved trunk control with more increased respiratory reserve. They're going to have pectoral girdle stabilized for lifting objects. So this patient will be able to use a standing table, which you see here in the picture to the left corner is that gentleman using a standing table to go into that upright position. This is not functional, but this works on orienting him to that vertical position, weight bearing on those lower extremities, and maybe working on a dual task of strengthening the upper extremities as well. The patient will be able to use bilateral knee ankle foot orthosis with spinal attachment for physiologic and therapeutic benefits. Again, not functional, it is just to get acclimated and working in that standing position for weight bearing purposes. Wheelchair, they can do a wheelie for 6 inch curb with proper training. Curb negotiation and wheelchair, they'll be able to go up a curb. They will be independent with all ADLs, and this is where the patient will start doing those floor to wheelchair transfers with varying levels of assistance if necessary. So you remember these transfers, you should remember these transfers from patient care where we practiced them, where you were sitting on the blue mat and you had to, without using your lower extremities, sit in the wheelchair. And there's various techniques on how to achieve that transfer. All right, so after focusing on T1 through T12, I do want to specially emphasize T7 through T12 because, as your book states, approximately at T7 is where that abdominal musculature kind of becomes really innervated, as well as the thoracic extensors. Please know that the lower the thoracic segment, the more control and the more function this patient is going to have. So I did want to shift focus a little bit to T7 through T12 because this patient can use a bilateral knee ankle foot orthosis with axillary crutches or a walker. Mind you, this does take a lot of energy for the patient, but the patient may be able to successfully use these crutches or walker and be a household ambulator, using the swing to or the swing through gait patterns. And this patient will also be independent with floor to wheelchair transfers. Now we move on to the lumbar spine. So the functional expectations and what muscles are innervated now at levels L1 through L3. So the muscles are the gracilis, the iliopsoas, the quadratus lumborum, the rectus femoris, and the sartorius. The patient is now going to be able to flex their hip, they're going to be able to adduct their hip, and they're going to be able to extend their knee. So functional capabilities are now continuing with ambulation. So this is the first level of functional community level ambulator using the knee ankle foot orthoses as well as the forearm crutches, not the axillary crutches. So now the functional expectations and what muscles are innervated at L4, L5, and S1. The muscles are the quads, anterior tib, the hamstrings, the gastroc. The soleus is also innervated at S2, gluteus medius and maximus, the extensor digitorum, the posterior tib, the peroneals, as well as the flexor digitorum. So now my patient has should have a better outcome in ambulation. So they have strong hip flexors, they have strong knee extension, they have knee flexion, ankle dorsiflexion, ankle plantar flexion, ankle eversion, as well as toe extension. So my patient functionally is independent with ambulation in the home and in community. Right? They have use of an assistive device. They also can use an orthosis, such as if needed, a knee ankle foot orthosis or an ankle foot orthosis. And the patient may require a wheelchair for long distances. So the components of intervention in this active rehab phase, um, they will include all of these here. So skin inspection still continues dependent upon the level of injury and the independence the patient may exhibit with all our rehabilitation. Range of motion is extremely important. Working on MAP programs. MAP programs focus on repositioning and getting into these different positions that you guys are learning with the stages of motor control and motor learning. Wheelchair mobility, wheelchair pressure relief techniques, gait training when applicable depending on the level of injury. FES is functional electrical stimulation, so electrical stimulation with functional activities, whether it be for the upper extremity or the lower extremity. Prevention, health promotion, and fitness and wellness overall. Being an open ear and a shoulder to cry on for patients and providing that emotional support is always extremely important for us as well as for the family members, and also continuing those activities from the acute intervention phase that are appropriate still in this subacute or active rehabilitation phase. So we continued once again with respiratory management, we continued with range of motion, we continued with positioning. We definitely progress resistive exercises for all remaining innervated muscles. We want to develop muscle reeducation techniques. We want to continue with regaining postural control and balance. Improving cardiovascular response to exercise was very important during this phase, and interval training with upper extremity ergometer and compensatory strategies. So how can we get in and out of the bed safely? Not the same way that you used to do it before, but safely transfer with using the musculature that we have available. So compensatory strategies are going to be very important for patients post-spinal cord injury. So now I just want to recap a little bit on skin inspection, and I talked about it already in one of the prior slides, but it's very important to reiterate it because sometimes it's overlooked. Education is very important, and advising our patients and our family members and caregivers to position the patient every 2 hours and reposition them, perform wheelchair push ups every 10 to 15 seconds for every 10 to 15 minutes of sitting is very important education to give that patient, obviously, the patient that is able to perform these push ups. And that is going to be, if you recall from the levels that we went over, at C7 is where the triceps are innervated. So we need those triceps in order to extend and push off from the chair or the sitting surface. Patient assumes responsibility to perform skin inspection or instructs the caregiver. So it's very important to obviously direct our education to the patient, and the patient will let the therapist know the if the caregiver is going to be the one responsible, then we instruct the caregiver as well with the patient present. You can suggest the use of the appropriate equipment, such as a wall mirror, or as you see here in the picture, which looks like a golf club, but it is a long-handled mirror in order for that patient to perform the skin inspections. Now we're going to talk about, still during this active rehab phase, what type of programs will we work on with our patient. And page 894 of your book starts with a couple of general progressions as to how we would start our patients moving in this mat, in the rehab gym or in an outpatient clinic, in the inpatient rehab or in an outpatient clinic. So general progression, stability, we want to work on stability in a posture first, then we want to work on controlled mobility, and then we want to work in skill, how we can use this position in a skillful, functional manner. So we want to focus on increasing patient strength, increasing functional range of motion, increasing awareness of the new center of gravity dependent upon where the injury is located, increase postural stability, and increase dynamic balance. So these are all things that we're going to be working on. We want to assist in determining the most efficient and the functional method for accomplishing a very specific task. Bilateral and symmetrical weight shifting and movement within a posture is extremely useful and important. You want to improve the patient's timing and speed, and you do not have to master one activity prior to moving on to the next. So mat progression, we work on rolling, we work on prone on elbows, prone on hands for paraplegic patients, supine on elbows, pull-ups for tetraplegic patients, sitting, long sitting and short sitting. Then we go to quadruped activities. We can do kneeling, sometimes half kneeling activities, depending upon the level of injury. And we also definitely work on transfers. So when working on mat activities, you want to remember that these patients are newly injured and they are now adjusting to their new center of gravity and their new base of support. So you don't want to forget your stages of motor control. Mat activities should be started as soon as the patient is cleared for activity by the medical doctor. And you want to include the patient in the problem solving process. It's their body, and sometimes they can they can come up with a better solution than we even can sometimes. As long as they are safe, we definitely will want to include them in this problem solving process. All right, guys, so the next couple of slides are going to focus on techniques that you should already be familiar with from completing your motor learning and stages of motor control lab. These techniques are going to be applicable to patients with spinal cord injury. So the first one we're going to do is rolling. And rolling is a focal point of a lot of mat progression programs, and it is a prerequisite for bed mobility and the ability of that patient to kind of transition from either a supine or semi-supine position to a side lying to a prone position. So we want to teach the patient rolling progressions using block practice and then progress to random practice. So we have several options. The patient can start in a semi-supine position with pillows behind their back, to side lying, then to prone with appropriate arm momentum. So you see here in the picture where that patient is starting in a supine position, using that momentum from the upper extremities to kind of roll to a side lying position. So patient can start in a semi-supine position with pillows behind their back, but you want to increase the distance by reducing the number of pillows behind the back to make it a little bit more challenging for that patient. Then from that supine with the legs manually crossed by you, or from supine with the legs uncrossed. So you have those two options. You want to remember the cervical and upper thoracic lesions do not have abdominals innervated or lower extremity musculature innervated. So that is going to be a little bit more difficult for those patients. You still want to teach them the same principles of looking and bringing the arm across their body. Patients with C5, C6, they don't have triceps, which is going to take away a huge leverage in the arms. So in order to help these patients, we put their arms into external rotation to lock the elbows into extension. And as long as they keep their arms, their shoulders below 45 to 75 degrees of flexion, they should be fine to use that momentum to bring them across and into a side lying position. Otherwise, gravity is going to pull their elbows into flexion, and it may not be as effective. We're going to practice these all during our Q&A session. So C7 and below, patients can use full 90 degrees of shoulder flexion, which will help their momentum because now the triceps are able to help as well. They do not have hand function, so they cannot perform the chop or the lift patterns that you learned during your motor control and motor learning lab. So we use shoulder horizontal adduction and momentum to bring them over into the new position. C8 and T1, and any injury that is lower can use the reverse chop, lift, and grasp hold to gain the momentum and bring them from that supine to side lying position. Patients need to roll for pressure relief, so you want to have them roll on the mat first, but they will need to learn how to roll on a bed as well. So the mat is going to be firmer than the bed, but we start with activities on the mat and then progress to their bed. Some patients with higher lesions, such as C5 and C6, may need to use a loop ladder, a triangle grab bar, or some other piece of equipment to kind of facilitate that rolling using their bicep musculature and the muscles of the shoulder that are innervated. So side lying on elbow. Concurrently, you're teaching the patient this while you're teaching them rolling because they're going from a supine or a semi-supine position into a side lying position. So hand placements are going to be at the scapula and the axilla on the downside and on the clavicular acromial region on the upside. So you have learned this technique as well during your motor control and motor learning. This is just a review that you can use this technique with patients post spinal cord injury. All right, then we have prone on elbows. So prone on elbows, the use of it varies with patients. It may be a functional position for some patients. For others, it may not work as well. Getting into the position will depend on the available musculature that the patient has. So the progression from easiest to more difficult is easiest is going to be manually placing them into the position and taking them through the stages of motor control. Teaching them then to prop on side lying on the elbow and then transition into prone on elbows is what the gentleman at the top picture is doing. He has gone into a side lying position, maybe from a supine. He used maybe the reverse chop pattern and momentum to bring himself into that side lying propped on the elbow, and then he's going to transition into prone on elbows. Then we have rolling from supine to propping side lying on elbow to prone on elbows using momentum. This means that you have to have taught them how to prop up on their elbow in side lying, and then they can roll independently. Then we have from prone with shoulders abducted to 90 degrees, elbows at 90 degrees using weight shifting, shoulder horizontal adduction, and scapular elevation. We also can do it from prone with shoulders adducted and elbows flexed under the body. And you can use weight shifting and shoulder flexion to try to bring yourself into that prone on elbows position. So the easiest way to kind of go through these, if you don't recall them from the stages of motor control and motor learning lab, is you can do them yourself. Put yourself in these positions so that you can kind of mimic what you're supposed to be teaching your patient. You want to check your hand position with your resistance when you're working on the stages of motor control. You want to make sure that you know which musculature is actually being innervated, because there's no sense in resisting muscles that are not there. So you have to know your levels and you have to know the available musculature in order to treat the patients appropriately. Understand what muscles are available, therefore which stages of motor control and motor activities are appropriate. In this position, you can strengthen the serratus anterior by pushing through the elbows into the floor and tucking the chin while lifting and rounding out the shoulders. You can do other upper extremity strengthening activities in this and the prone position, so you can reach, they can elevate if possible, if dependent upon what they have innervated with their level of injury. Then we move on to supine on elbows, which is beginning functional position to move into long sitting. So this is the patient that went from that, maybe they were in the prone position, they were able to prop prone on elbows, and then after that they went side lying on elbow, and then they went into that supine position with the assistance, obviously dependent upon what the patient's injury level is. And now they're going to get ready to go ahead and sit up into a long sitting position on the mat. So getting into the position really will depend on the available musculature progression from easiest to more difficult. Obviously, the easiest is going to be us manually placing them in the position and then taking them through the stages of motor control. Teaching them propping from side lying on elbow and then transitioning into supine on elbows is a little bit harder. Rolling from supine to propping side lying on elbows to supine on elbow, this means you have already taught this patient side lying on elbow and they can roll independently. Then we have prone on elbows, if they have worked in prone on elbows and then can do it static, dynamic, controlled mobility stages. From supine, you want to stabilize the hands by putting them under the gluteals and or in the pockets. Then you want to lift up by forceful contraction of the biceps in increments. Shift weight side to side as the elbow continues posterior. You want to check your hand position with your resistance for stages of motor control. This just means that you want to make sure that you're not resisting any muscles that are not innervated, because there is no use in doing that. You only want to use the available muscles. Okay, so then we're going to talk now a little bit about the long sitting position. This is essential for ADL such as dressing, self-range of motion, transfers, and wheelchair mobility. Getting into this position is going to depend on what available muscles the patient has. Progression is listed from easiest to more difficult, and easiest being manually placing them into the position and taking them through the stages of motor control, going from supine on elbows to long sitting, going from prone on elbows to long sitting, walking on elbows to semi-side sitting to long sitting. For those that need more assistance, a loop is going to make it easier for them, or a ladder or a triangle grab bar. So in the picture on the top, you see that the patient is in that prone on elbows position, and they're going to kind of walk on their elbows towards one side into a C position that you see here. Once they go into that C position, they're going to use the elbow that is going to be closest to the legs, and they're going to hook that elbow under their lower extremities. That's letter E if you look at the diagram. At a certain point, the patient can then shift their weight on the off of the weight bearing elbow into their hand, which you now see on letter G, where the person has now, instead of putting their weight on their elbow, on the right elbow, now their weight is on their right hand. After they do that, then they're going to push with one arm while pulling with the other up to a long sitting position. So that is the final position that patient is at, which is letter I on there. And we're going to be practicing this in the during the Q&A session as well. So just a couple more things here regarding long sitting. They may need to use a mirror for feedback. They don't have the sensation to tell them where their body is at times, so visual feedback is definitely important. Patients with C5 and C6 levels are going to need to keep their shoulders in external rotation because they do not have the triceps available, so they have to keep those elbows locked. Their arms are just going to collapse without the external rotation component. Patients with C5, C7 will want to keep their fingers flexed and use the base of the hand so they don't lose the tenodesis. Going through the stages of motor control with the arms behind, and then progress to getting the arms to where the hands are at the level of the greater trochanter. The head and the body will need to lean forward or they're going to fall backwards. So you want to work through the stages of motor control at each position change, from the hands behind to hands at the greater trochanter. Then they can do long sitting push-ups. These are very important for transfers because they need to push off from the surface where they're moving from. If you help the patient, don't grab under or around the axilla because this is going to counteract the depression of the shoulder. You want to lift under the gluteals or at the gait belt if you're helping them with these long sitting push-ups. Moving forward from the long sitting position, you want to start with the trunk, the head, and the neck flexed. Do a push-up and rapidly extend to try to shift forward. To move backwards in the long sitting position, you want to start with a neutral upper trunk, and you want to do a push-up and rapidly flex forward at the head, neck, and trunk to move back. Moving sideways from this long sitting position, to go to the left, you want to move the left arm slightly out and then do a push-up with a rapid rotation of the head, neck, and the trunk to the right, and then you use the opposite concept to go to the right. So once again, it's much easier if you practice these as they are being described so that you can better explain these to your patients when you are working with spinal cord injury patients. The next position we have is short sitting. And short sitting, patients with a C5 lesion are going to have a difficult time with this position because of the limited availability of innervated musculature. They're going to typically have very poor posture with a forward head. So you want to start this with the patient in the wheelchair if necessary, and you want to have them practice sitting against the backrest and then away from the backrest so that you can assess how good of a balance the patient has, as well as the stability that the patient has. Then you want to continue with the progression to the mat as soon as possible because we need to work on this balance, and it is difficult for them to achieve, so they do need a lot of practice before they are either discharged home or before they progress to the next activity. Therapists should sit behind the patient, as patients are always in fear that they're going to fall backward with that backward momentum. So you want to make sure the patient knows that you will not allow them to fall. They need this security as they are very unstable and very unsure of their balance. You want to have them practice with the hands to the side or behind them, whichever level they need to start at, but have them progress to the arms supported at the sides. Continuing with short sitting, then you want to have them progress to the arms resting on their knees, as you recall from balance assessments during test and measurements. Then you want to begin with unilateral arm raises with the other arm supporting on the mat. Begin with the arm at the side with with elbow flexion, then shoulder abduction to 90, then shoulder flexion to 90, then overhead, if possible. This is very difficult in those patients with cervical and high thoracic injuries due to lack of trunk control and the higher center of gravity with the arms overhead. Then you want to go ahead and switch to the other arm. So this is just a couple of progressions, a couple of exercises that you can do with the patient. Once again, taking into consideration the level of their injury. Then you want to progress to bilateral arms at the sides with the elbows flexed, then progress to arms raised to 90 of abduction, then 90 of flexion, and then overhead. During each of these activities, if the patient is learning a new balance control technique. So with those patients that have lower thoracic levels of injury, you can take them through the stages of motor control. Again, it all depends on the level of injury and what musculature the patient has innervated. Other possible functional positions depending on the level of injury. First one being prone on hands. So note that for paraplegics, this may not be appropriate for all. This specific position has the functional carryover to include development of the initial hyperextension of the hips. So we are focusing here on being prone on hands in order to encourage later on the ability of this patient to hyperextend their hips and their low backs in order to use this locking mechanism for ambulation later on, for standing from a wheelchair or rising from the floor with crutches and bilateral knee ankle foot orthoses. From this position, you can also do some lateral weight shifting with weight transfer between the hands. This will increase joint approximation, as well as scapular depression, and prone push-ups can be used as a strengthening exercise in this position. The next position that we're going to talk about is quadruped, and it can be used for paraplegics. It is an important lead up to ambulation if appropriate. It allows for weight bearing through the hips, and it can also facilitate initial control of the available muscles of the lower trunk and the hips. Then we can also use tall kneeling. It's a paraplegia progression to ambulation for appropriate levels. And learning to control pelvic anterior displacement is very important for those patients that are going to be ambulatory in order for the forward progression of gait. So continuing on with the active rehab phase, we will talk briefly about functional electrical stimulation, and this is electrical stimulation that can be utilized to um, facilitate either gait training, breathing, upper extremity function, functional tasks, cardiovascular training, standing, or ambulation, bowel and bladder function. So this is electrical stimulation that is applied in order to facilitate all of these items that are on the slide. So the next couple slides are going to talk about prevention, health promotion, fitness, and wellness, and some things that are common in patients with spinal cord injury. Shoulder pain is a common thing in spinal cord injury patients. It's usually biomechanical. It's due to weight bearing, wheelchair use, poor sitting posture, decrease in range of motion. Other contributing factors are the patient's age, the patient's body mass index, the level of the injury, and any muscle muscular imbalances that the patient may have going on. Exercise is important, so some of the advantages of endurance and resistance training include increasing the patient's function, increasing strength and endurance, increasing respiratory function, increasing perceived health and quality of life. And some examples are upper body ergometers, wheelchair propulsion counts as exercise, swimming, circuit training, wheelchair sports, free weights, weight machines, and TheraBand. Strengthening 2 to 4 times a week, 2 to 3 sets of 8 to 12 repetitions at 60 to 80% of the one repetition max is just an example of treatment parameters. And then push ups on prone on elbows is just another example of an exercise that is appropriate for patients with spinal cord injury dependent upon the level of the injury. So concurrent upper extremity and trunk strengthening is very important, and obviously lower extremity where applicable, but it all depends on the level of injury. You want to just know that you want to focus on strengthening appropriate muscles based on the level of the lesion. So there's no use in strengthening a C6 tricep musculature because the triceps are not innervated. So that's the way that you have to think. You utilize PNF diagonal patterns, all shoulder musculature. You can use weights, pulley systems, TheraBand, resisted motions, abdominal and trunk musculature in the levels where it applies, and any lower extremity musculature that is innervated is able to be strengthened dependent upon if there are any contraindications, if you recall from earlier in the lecture. And these are just some of the activities that we can use. Again, we can use TheraBand, we can do aquatic therapy, we can use lower body ergometers, upper body ergometers, cable columns. So these are just some of the sample exercises that our patients with spinal cord injury are able to do. All right, and the final thing we're going to be talking about when it relates to prevention, health promotion, fitness, and wellness is education. Extremely important to educate your patients, instructing as well the caregiver or the family member that is going to be the caregiver for that patient. You want to address lifelong management of the patient's disability. You want to address community reintegration. You want to focus on maintaining optimal health and function, housing, nutrition, transportation, finances, employment, and recreational activities. You want to provide that emotional support that I talked about earlier on in the lecture. And you want to encourage the patient and the family members to express their feelings, their fears, their concerns. Sometimes they become depressed, so all of this is going to be related to you for you to provide the proper education that is required and the support. So transferring patients with spinal cord injury or transfer training, this is going to require sitting balance. It's going to require momentum. It's going to require the use of other muscles or muscle substitutions. For example, the patient will require to lean forward using their upper extremities if that's available, and the abdominals are not available, for example. So they have to substitute with other musculature that is innervated. We have to teach the patient the head to hip relationship. They have to be able to shift their head to one side while their hips go in the direction of the transfer in order for them to move across that transfer board if they're using a transfer board. Without the use of the transfer board, the patient may be able to transfer using a lateral scoot transfer where they're just scooting into that new surface. So transferring from the wheelchair to the mat and back using appropriate transfers for appropriate level, maybe with the lateral transfer, maybe with the transfer board, but these are appropriate transfers for level C6 and any lower levels. Above C6, the patient is typically dependent on the attendant or the nurse or the therapist to use a mechanical lift. Wheelchair to floor and back using appropriate level only. Once again, floor to wheelchair is going to be with those patients that are appropriate. So you have to recall back to your table on page 883, depending upon what musculature the patient has available, and in order for them to get from the floor to the wheelchair and vice versa. Ambulation requirements. So, functional ambulation is not possible for spinal cord injury patients above T11. The criteria for candidacy to be able to be ambulatory is obviously the level of the injury, the adequate muscle strength, especially in the upper extremities, because these assistive devices are managed by the upper extremities. Postural alignment is very important. Range of motion, they need full hip extension in order to be ambulatory. Cardiovascular endurance is extremely important as they are taxing. It's a very taxing activity, functional activity to ambulate post spinal cord injury, and the goals of the patients. Very important to look at those. So now let's look at some ambulation pros and cons. So advantages for the general well-being of the patient to be eye-to-eye level with the therapist, be eye-to-eye level with their family members. It increases circulation, it improves skin integrity, it improves bowel and bladder dysfunction. Disadvantages, it is going to be very, very energy expending. So it's going to require a lot out of the patient. For a paraplegic, it's 2 to 4 times the normal energy expenditure to ambulate. Thoracic spinal cord injury, 9 times greater energy expenditure with orthotic per meter than a normal adult. So it takes a lot out of the patient to ambulate post spinal cord injury. The cost of the orthotics and the training is very high. Ambulation is going to be very slow and it's going to be laborious. It's going to take a lot of work for that patient, and it's often non functional. So, that patient that has been ambulating or is a candidate for ambulation may require the use of orthotics. So, the KFO is on page 1336. You should be familiar with this from your orthotics lecture. The ankle is locked at 5 to 10 degrees of dorsiflexion. There are some with occasional pelvic bands and spinal attachments. There is also a Scott Craig, which has a bail locks and it's standard double uprights. And then we also have the reciprocating gait orthosis, which is a dual cable system. Movement of hip in one direction facilitates contralateral movement in the opposite direction. And then we have the AFO for those that are L3 injuries and below. So very, very costly orthotics. Some of these are, which definitely a disadvantage to those patients that are ambulatory. Some gait strategies. So the goal is going to be swing through the gait using the crutches and using the knee ankle forward orthoses. So now we're going to talk a little bit about some of these gait training components that are very important to just have in mind when your patient is an ambulatory patient post spinal cord injury. So donning and doffing the orthoses, sit to and from stand activities, trunk balancing, push-ups, turning around, ambulation activities in parallel bars, the assistive devices that your patient may use, sitting to standing from a wheelchair, balancing the crutches, ambulation activities, travel activities, curb and stairs, and how those are managed, and falling. So putting on and removing the orthoses, the patient is first taught the correct way to don and doff the orthosis. So that should be number one. Typically in supine or long sitting position, And you also want to educate and caution the patient to continuously monitor their skin for any areas of unneeded pressure, um, because we don't want the orthosis to lead to a pressure ulcer. So, particularly after brace removal, it's very important for you to educate the patients to perform a skin inspection. Right, when a patient is first learning how to stand from the wheelchair, they typically wheel the chair to the parallel bars. They slide to the edge of the wheelchair. They lock and unlock the orthoses, and they go ahead and pull on the parallel bars to come into a standing position. In order to progress, they, instead of pulling on the parallel bars, they push up from the wheelchair. And then from standing to sit, they just reverse the process. So static standing balance, the patient is going to learn to balance in standing with the hips in hyperextension and the upper trunk, the head, the feet and arms behind the pelvis. So basically they're leaning into the anterior Y ligament of the hips. This is going to create stability at the trunk and the pelvis. Full range of motion is required for this. The weight here is being balanced over the feet, and the progression, the upper extremity support progression, is going to be bilateral upper extremities being holding onto the support surface, then one upper extremity off, then both upper extremities off. So push-ups are a good practice technique to progress later on to stepping forward. Uh, what we do is in the parallel bars is usually where we start this progression, and it's lifting the body off of the floor using elbow extension and scapular depression and protraction, and then you lower the body down while maintaining balance. This is going to be to progress to lifting and stepping later, and it's done parallel bars initially and then outside of the parallel bars with crutches, um, as well as before stepping outside of the parallel bars with the crutches, you do with the crutches inside of the parallel bars as well. Okay, so ambulation typically starts in the parallel bars. Just know that swing to and swing through gait patterns require varying amounts of body elevation and push off. And when we use the 2 point and the 4 point gait pattern, they require hip flexion or hip hiking in order for that pattern to be successful. Compensations with spinal cord injury to look for. With patients with high lesions, the internal obliques and the external obliques in the latissimus. With a low lesion, the quadratus lumborum will compensate. Trunk rotation on the swing side with forward progression, you'll see as a compensation, or trunk lateral flexion on the stance side with forward progression is a compensation that you may see with spinal cord injury patients. Again, these compensations will make these patients ambulatory, but it's still considered a compensation. All right, guys, so in parallel bars, the patient is going to present with an anterior pelvic displacement, which is necessary in order for ambulation to happen, because they need to have that hip in hyperextension, and they need to lean all their weight into that Y ligament to use it kind of like as a locking mechanism for ambulation. So some ways to practice in the parallel bars, as you see in the picture in the top, there are two techniques to do this, and this is to work on that anterior pelvic displacement. So first you start with the hands gradually anterior on the bar, just having one hand, then both hands, and then both hands off of the bar, while keeping that anterior pelvic displacement. Then you can also do hands gradually posterior on the bar, just one hand to the back, then both hands to the back, and then both hands off of the bar in the back, while keeping that anterior pelvic displacement. We can also practice push-ups, so holding on to the parallel bars and pushing off of the ground and then back down. And then you can also do the jackknife technique, which is bringing the trunk into that forward flexion, as in like you're opening or closing a jackknife. And these are all techniques that are going to be used during ambulation. So they're very important to practice at first in the parallel bars. When turning, the patient typically lifts and then lowers their body in 90-degree turns in the parallel bars, and then changes from the parallel bars from one hand to the other hand as they're turning, because they have to switch the hand as they do that turn. All right, so when we're talking about assistive devices for patients with spinal cord injury, we typically see the forearm crutches because they are lightweight. They can use the hands without dropping the crutch. They're easily maneuvered into a car. They improve functional ambulation, and they're easier for stair climbing because it allows for full hip extension and unrestricted shoulder motion. So loft strands can be used on even surfaces and then progressing the patient to uneven surfaces. Page 898, figure 20.24 shows you the swing through gait pattern with the use of the loft strand crutches. In order for the patient to assume a standing position with crutches, the patient moves forward in the chair. Then they are going to lock both knee joints, cross one leg over the other, and then proceed to rotate the trunk and the pelvis. The hand placements are going to be on the armrests, and the patient is going to push to a standing position by pivoting around to face the chair. Once they are facing the chair, they have to reach for one crutch, which should have been positioned behind the wheelchair. Then go ahead and reach for the other crutch, and they are in that standing position and ready to ambulate. These are just some pictures of standing frame or standing table, again, for not so much as functional activities as they are for physiological standing and the benefits of physiological standing that we discussed earlier in the lecture. We also have body weight support systems where there are systems that will harness the patient and will work on weight bearing activities, gait training activities. Again, not the most functional, but it is systems that will facilitate gait training in those early stages in the active phase of recovery. Then we have ambulation activities, which we talked about already. So practicing of the 4-point gait pattern, the 2-point gait pattern, the swing 2 gait pattern, the swing through. You want to progress from slow, steady gait to faster, unstable gait to stable, faster with appropriate timing and speed. And then community activities to get that patient ready for community re-entry. We can practice sidestepping, backward stepping, continuing to practice turning, walking through doorways, and unlevel terrains. Okay, so when specifically working with patients' spinal cord injury diagnosis, the easiest way to ascend the stairs as well as a curb is going to be backwards for that spinal cord injury patient. And the easiest way to descend is going to be forward using a handrail. And this applies for curbs and it also applies for stairs. And the last thing we're going to talk about is falling. So teaching the patient controlled falling and getting up from the floor. That's just coming off of the wheelchair and getting back into the wheelchair, or being able to do that. Obviously, at first we would start with assistance from us, and then hopefully our patient would be progressing to doing this independently. And we did some of this during patient care when we did the transfers from floor to wheelchair and wheelchair to floor. And that is the controlled falling from the chair to the floor, for that patient to have as much independence as possible. And finally, we have some pictures of some additional activities that patients with spinal cord injury are able to participate in. And guys, that concludes the lecture on spinal cord injury. I know it is a very long lecture, but make sure that you please, if you have any questions, you come to class with questions, or if you need clarification, and we will practice some of these techniques that we talked about, specifically techniques that you have already learned from the stages of motor control and motor learning, and how we can apply them to now if you are presented with a case of spinal cord injury.